thing. Perfect. So I think everybody knows that today we are joined by Michelle Weinberger, who's going to give us a bit of an orientation to the 2024 LEAP report, and kind of walk us through how to use LEAP and then different ways that we can apply it for advocacy. But before we hand it over to Michelle, B, I know you were going to give us a bit of an opening to our call today, so I will hand it over to you. So over to you, B.
Thanks so much, Sarah. Appreciate it. As many of you know, one of the key objectives of the AAWG is bringing evidence-based advocacy to bear. And what the LEAP report provides us with an excellent opportunity to do that. Our colleague, Michelle Weinberger, worked on providing this year's LEAP report, which had extensive data and really important key results to help guide future decision making. And one of the key things that they've generated or they've developed is this tool to be able to provide easy to digest, understandable data. And then Michelle is going to take time to walk us through that. And we're going to be able to then use this opportunity as an interactive exercise to generate to walk through how we might use that evidence to generate advocacy messages. So I don't want to talk for too long. I want to hand it right over to Michelle to walk us through or give us an overview, and then we'll start doing the more interactive part of this session. Michelle, over to you.
Great. Sarah, it is telling me that the host disabled screen sharing.
You should be good now. Try now.
Okay. Perfect.
Thanks, Michelle.
Great. And we're a smallish group today, and happy to keep this kind of fairly informal. But the plan for today is I just have a couple of slides with a little bit of background on LEAP for those who are maybe less familiar with it or have not looked at LEAP in a while, to just sort of remind us of what it is. And then our plan is to spend the bulk of our time together really just getting into the report itself. So I'll bring up the report on my screen. We've sort of come up with some advocacy questions as a starting place, and we'll think about how we could find answers to those questions within the report, but really want this to be an open working session. So look forward to hearing from you all about things that you want to take a look at as well. And then we just want to reserve a little bit of time at the end for some sort of future brainstorming about how we could kind of better make the linkages between the LEAP report and all the data and information we have and advocacy efforts. So what kind of additional tools or guides or future sessions like this would be helpful to make sure that we're really getting the most out of LEAP. So with that, I will jump in. So LEAP brings together 4 different areas to look at supply needs sort of across a woman's reproductive health life cycle. So looking at contraception, menstrual health, abortion impact, and maternal health. Well, the history of LEAP is really just rooted in contraception. The commodity gap analysis is a long-standing product of the Supplies Coalition. The very first one, I actually think, even slightly predates RHSC. And so for many, many decades, there had been this report that really just focused on contraception. And over, I would say, probably the last 10 years, the last 5 to 10 years, that report expanded. So looking across a wider set of countries, looking more deeply into the public and the private sector, and really kind of taking a more nuanced look at what is happening in contraception. And then in 2021, we, for the first time ever, expanded LEAP to look into these other health areas. So the 2021 report added this new analysis to look at supply needs for menstrual health, abortion impact, and maternal health. And then in this 2024 LEAP report, which was recently launched, we then sort of did an update. We updated all of the data sources that go into the report, and then also made some updates to what we are showing, which I'll talk about in a little bit. So at its heart, LEAP covers kind of three key things. It looks at the people who are needing and using key reproductive health supplies. It looks at the quantities of drugs and supplies that they're using, and then it looks at the costs of these drugs and supplies. One important thing to note is LEAP is really just focused on the cost of the drugs and supplies. So it means we're not capturing things like the cost of service delivery. So we're not capturing provider salaries, we're not capturing infrastructure costs. It's really just this supply piece, which we know is really critical, but it's just helpful to remember when we're thinking about how these numbers compare to, say, numbers in the Adding It Up report from Guttmacher. We're sort of looking at a narrower view of that picture. LEAP builds a current landscape, looking at data for 2023, and then projects into the future with a kind of stop point in 2029 and then out to 2035. And we now, for all the health areas, look at three different future scenarios, which we'll spend some time talking about today, that look at how things could change and what are the implications of those changes for the supply needs and the cost of those supplies. We cover 132 low and middle income countries. The analysis is presented by individual country, by region, and then we have a whole section of the report where we're really looking at differences across income groups. So that's low income, lower middle income, and upper middle income countries. So when we dive into the report today, we'll take a little bit more of a look into those different ways of slicing and dicing the data. So this image is showing all of the different types of data that feed into LEAP. And you can see that we're pulling together a wide range of different type of data sources. So we're using projections from the UN Population Division. We're getting a whole lot of different information out of household surveys like DHS and MIX and PMA. We use research and other models to get inputs around kind of the prevalence of different diseases, abortion incidents, different needs. And then we also draw on price and sales volume data from a range of different sources, trying to look at both public and private sector price points for supplies. The boxes that are in yellow indicate new data sources that were integrated into LEAP 2024 that we hadn't previously been using in 2021. And then all the data sources were refreshed and updated where there was new data available. So just a quick summary of key changes, and then we'll take a look at the report itself. Um, so this year, for the first time, we introduced future scenarios into contraception. So we'll spend some time looking at those today to really try to align contraception with the other health areas that had these future scenarios in the 2021 report, and to really support some strategic discussions that are happening right now in our community about the future of financing of FP commodities. For menstrual health, we added a new category of mixed product use so that we could account for women who are using a combination of both reusable and single-use products. We use new data sources for medical abortion to better capture the costs as well as the use of misoprostol alone versus misoprostol in combination with mifepristone. And we also have a more probing analysis into maternal health, looking at a new product, which was multiple micronutrient supplements, MMS, which are being proposed as a potential replacement to iron and folic acid for pregnant women. And so we explore what the implications of that would be in terms of cost and use. For each of the reports, we have four different essentially tools. So only two of them are available right now. Two are just getting finalized, so will be coming soon. So maybe come back to this group when those are available and talk more about how those can be used. But first, each health area has an overview report, which is a dynamic report that can be produced for any selected country or region. I should note that for abortion and PAC and maternal health, we only present results by region and not by country. And that's because we have a lot more limited data in those health areas. And so made the decision that we felt the country level results were not kind of robust enough to be used at a country level. So for those, we limit to regional results. Each health area also has a global GNI comparison report. And so this report is really focused on understanding differences and patterns across low, lower middle, and upper middle income countries. And then soon to be launched will be a comparison data explorer, which will let you see how things vary across countries or regions, as well as a product deep dive. And these are similar to tools that existed in the custom reports feature of the 2021 LEAP report. So the product deep dive lets you select one single project. So for example, contraceptive implants, and has a whole lot of results about where implant users are, the volume of products being used, and how that might change under the different future scenarios. So with that quick overview, maybe I'll just pause for a second to see if there are any thoughts or questions, and then we can turn over to our more interactive part of the session. Great. So for this, I will switch my sharing to share the LEAP report, but just wanted to share some kind of initial questions we had come up with, but also really want this to be a open and interactive session. So if people have other things that they want to look at in the data, or think about how you can kind of find results linked to key questions, please do share those. But we thought we'd kind of go through each health area so that we could see what results look like across all of them, starting with contraception, with sort of an exploration of the roles of the public and private sectors and the implication of future changes. Next, we're going to look at menstrual health. And we're thinking here we could look at this question around what would it take to get improvements in the share of women who are using purpose-made menstrual health products. For abortion and PAC, we have some key questions around medical abortion and what that spending might look like in the future. And then for maternal health, again, just thinking about how much it would cost to see improvements in the use of key maternal health drugs. Just give me one moment and I will pull up the LEAP report. Great. So on the LEAP homepage, you find just some general background information, and then you can get to your health area of interest either through these boxes here or navigating through these menus at the top. So we're going to start on contraception. We can see the different reports. Also to note that there's an option to download all of the data. So you can just get an Excel file with the data and do your own analysis and graphs as you wish from that. So we're going to start with the overview report. And our question for this was around the roles of the public and private sectors, and that we see very distinct roles of the public and private sectors. And so what would be the implications of changes? So we're hearing a lot in our community that, as donor funding is more limited, and that if country governments don't kind of step up, that we might expect to see an increased role of the private sector. And what might the implications of that be in terms of choice and affordability? Okay. We are gonna, so if you see here in this box, you can kind of scroll through and you have a choice of different income groups, different regional splits, some kind of key donor priority groups, and then individual countries. For this one, we are gonna take a look at Burkina Faso, at least initially, and then have data open up to the group. And when you make this selection, all of the graphs and the text update to showing you results for that country. So you can see now the text over here says that there's 1.58 million contraceptive users living in Burkina Faso. So the idea of having this kind of integrated dynamic text was that it would make it really easy for advocates to not only kind of copy out graphs, which you can download as an image, and then be able to put into a PowerPoint presentation, but also could just copy out this text and have text that kind of formulates those results for you. Sorry, 1 second. I'm gonna actually come back up again. We're gonna look at Ghana instead of Burkina, so we see a little bit more dramatic differences, and then we can come back again to some other countries. Great. And I think Ghana, Ghana is a country where there's lots of eyes on what financing might look like, and with donors kind of working to step back their commodity financing. So I think it's an interesting one to think about what that might look like. So one thing we can see here is the method mix of the public and the private sector. If we turn this graph into relative terms, and these become kind of full bars, and so we can see, as we see in many countries, these very distinct patterns, right? So within the public sector, you have a large share of women using implants and injectables. And within the private sector, you have a lot of use of pills, condoms, and other modern methods, which in the context of Ghana, a lot of that is emergency contraception. It is a method we have thought about bringing into the analysis overall, but in most countries it remains very small. Ghana is probably one of the biggest exceptions to that. And so don't feel like we yet have sufficient data for it to kind of come out of that other modern method group. This next graph is showing that same data, but just kind of thinking about it in a different way to say for each method, what is the role of the public versus private sector? And so again, you see this really dramatic split where the vast majority, so kind of 80, 85 to 90% of those who are using injectables, IUDs, implants, or sterilization are getting their methods from the public sector, whereas those using pills and condoms are almost exclusively getting their method from the private sector. So this just very stark picture of differences. There's also some similar results around costs. So costs tend to be more skewed than use because we know that the costs of methods differ, and short-term methods generally have a kind of higher cost over the course of a year, because women need, lots of condoms, lots of pill cycles, and we're applying different costs in the public and private sector, accounting for the fact that not always, but often those private sector commodities have a higher price point. And so we see similar graphs showing that picture of cost rather than just use. And then we get to our future scenarios. So for contraception, we've modeled these 3 different future scenarios. The first is that we maintain the sector mix, so basically nothing changes. The role of the public and private sectors remain as they are at our baseline. In scenario 2, we explore an increase in the role of the public sector. So we modeled this as a doubling of the share of users going to the public sector with a few parameters around that to just kind of keep things within a range. And then our third scenario, we modeled the doubling of the share of users going to the private sector. For these scenarios, we assumed that the methods women get within the public and private sector stay the same. So we wanted these scenarios to really say what would happen with a big shift in sectors without other efforts that would either change what methods are available from public or private providers or change how those methods are financed. So it's sort of saying, if we see these changes without these other changes, what are the implications for choice and affordability? With the idea that this might help seed some important discussions about what might need to be in place if we really want to see drastic shifts in the role of the public and private sectors in terms of supporting those sectors to either provide a wider range of services or have creative financing mechanisms that allow for those services to be financed and not just sort of shifting that burden to women paying out of pocket for their contraception. So this graph just shows the current overall mix in Ghana. So you have about 64% of users going to the public sector and 36% going to the private sector. In our increased public sector, that jumps up to 95%. So that doubling kind of pushes it up to our maximum. And in the increased private sector scenario, the private sector share would jump up to 72%. So then here we can see what the overall implications for method mix would be of these changes. So not surprisingly, when we increase the public sector, we see an increase in injectables and implants, since those methods are primarily sought from the public sector. And if we increase the private sector, we see a shift in method mix towards short-acting methods, since those short-acting methods are generally sought from the private sector. And again, all of these graphs can be downloaded either as an image or as a CSV, which just gives you a little Excel file with the data. And again, all of the text is updated to kind of give that narrative of what is happening in the graphs. So if we look ahead in Ghana of what this means, we see that contraceptive use is expected to increase from about 2 million users in 2023 up to 3.4 million in 2035, so a 67% increase, so a fairly rapid growth. And this is a combination of population growth as well as increases in contraceptive prevalence. And so if we layer that growth across our different scenarios, then we can see how changes would happen by method. And so again, this is kind of similar to the method mix graph we saw above. So the orange line is our maintain, the kind of teal color line is our public sector increase, and the purple line is our private sector increase. So we see with the public sector increase, we see those increases, especially for long-acting and permanent methods. And we see with the private sector increase, big increases in the use of pills, condoms, and other modern methods. And so, I think this is an opportunity to think about how do we use these results to talk about choice and ensuring that, with these changes, women are still able to access a full range of methods across the public and private sectors, and that we don't sort of inadvertently reduce choice by having these changes happen without additional things in place to support what that might look like to have a full range of methods available. And then very similarly, we can see this result for costs. We see a much more dramatic picture here because of the sort of higher costs associated with those short-term methods. And so see big shifts in terms of what the total costs would look like, but also in terms of where those costs would come from. And again, the kind of baseline assumption in LEAP, this is something be good to discuss more, is that, in most country contexts, women who are accessing methods from the private sector are paying out of pocket for those. Right? There might be some small coverage of different types of financing schemes. There is, some subsidy within the private sector in some cases, but that is primarily out-of-pocket expenditure. So again, thinking about a future where you have this dramatic shift from the public sector to the private sector, what does that financing look like, and what might be able to be put in place in terms of, coverage in universal health insurance schemes, in terms of other kind of contracting out mechanisms, to think about what could be done to kind of mediate that change so that we're not kind of seeing an unaffordability of contraception if we were to see this drastic change between the public and private sector. So I'm going to pause there and would love to hear thoughts, and if there's other stuff that people want to go back and look at a little bit more closely in this section. Also just curious to hear to what degree this kind of resonates with conversations that are happening in the working group or in your other work outside of the working group as well.
Yeah, and maybe to probe on that one a little bit, Michelle, I think, one of the central sort of themes in the ANA work plan this year and in past years has been around financing and thinking about sort of how we're paying for contraceptive commodities and other RH supplies and kind of who the payers are. So to people on the line, curious kind of in seeing this data and in thinking about some of the trends and the costs, how could we apply what's here for some of the advocacy messaging or some of the advocacy asks that we're making? Yeah, curious to hear thoughts from people. And Amos and B, feel free to jump in as well. I know you both have a lot of thoughts about this.
Thanks, Sarah, and good morning, colleagues, and good afternoon. So, colleagues, let's give feedback as much as possible so that we are able to see how useful this data can be. Thank you.
And say one, we kind of zoomed into a country, though I see some hands, so we can go to that and then come back to this. But I also think that like bigger picture and the comparison across low, lower middle, and upper middle income countries and how that kind of current financing picture varies is also be helpful at a kind of higher level of advocacy. But yes, Sarah, I see your hand up.
Okay. Let me see if my video will start, but maybe not. Okay. We're restricted to the browser version, so sometimes there are some limited functionalities of that have to turn on other stuff. Anyway, so I want to make sure I'm understanding this because, we invest so much in the public sector in many of the projects that we're working on. And so that can, for the Ghana example, consistently shows the implants, which are long acting, and injectables, which are short acting in the public sector, and then the pills and condoms in the private. But that cost seems so much more dramatic over time. I think that actually maybe one of those graphs. But so I just wondered also about sort of the advocacy to get more long-acting methods into the private sector, if that wouldn't also have some overall cost savings for everybody. There maybe is a little bit more upfront costs for the private sector providers in the training and the equipment / supply / commodity. But sort of longer term, would it not be lower cost? So that just struck me a little bit.
Yeah, no, I think that's a great point. I mean, I think, right, and this is going to vary country to country and not a level of detail we have in LEAP, right? But, I think there's some of that is sort of who makes up the private providers in a country. And do you have kind of a clinical cadre that could provide those methods? And then also, and we see this a little bit if we kind of get into the details of the cost data, but then to what degree, so like, could those private providers access those $6 and $8 implants, or are those private providers, having to buy implants through more commercial channels where they're paying much higher prices, which we definitely see, I would say, in a lot of Latin America countries and other contexts as well. So I think those are great points, Sarah, but maybe just some like additional things to think about around what that advocacy looks like and what those next steps might be. Great. Allie?
Thanks. This is really interesting. I'm wondering if it's interesting to see the projections into the future, but are there past LEAP reports that we could look at to see how things have changed over the last several years? And I'm thinking about also like what, if we can see those changes, what type of advocacy was done in different countries, or how policies were changed, and kind of use that as our advocacy as well. So I mean, I don't see it here, and I can see that it probably doesn't necessarily make sense for the report that you did, but did you guys look at policy change or look at the policy environment at all as part of this as well?
Yeah, I would say LEAP is probably not the place to see those pastime trends. We have cautioned against sort of comparing between old LEAP reports because there's lots of different things that change that aren't necessarily just the survey data, and there's lots of countries that maybe didn't have a newer survey, so you're kind of not picking up that change. So I think there are other tools that are probably better suited for doing some of that, like retrospective analysis. And for that, you're probably better off just going back to, looking at the last two DHS surveys and seeing what changed in between them. Um, and for LEAP, because we're doing analysis across 132 countries, right? We're really kind of just giving the what and not the why. But I think that's also a place to think about, if we look at Ghana and then we look at another country that has a really contrasting picture, that then there's an opportunity, right, for this community and for others to bring that narrative to it, to say why does the contraceptive market in Ghana look so different to say the contraceptive market in Senegal or even in Nigeria, right? And be able to talk about, the role of donors, the role of governments, the role of different policies in shaping what some of those differences are. And a plug for the forthcoming kind of comparison report where you'll be able to kind of have a graph to say, like, what is the share of public and private sector across all countries in, say, sub-Saharan Africa or Western Africa. So get that kind of comparison snapshot very quickly and easily. Great. Would folks like to spend, I know a lot of this group is very focused on contraception, so we can spend more time here, or if people want to jump to look at one of the other health areas, happy to hear what might be of interest to take a look at and maybe kind of prioritize based on interest, because I don't know that we'll have time to go through all four.
Actually, that's a great opportunity to sort of segue into one of our recent discussions with our maternal health and maternal neonatal and child health colleagues on the discussion that we had last month on the priorities of commodities for MNCH. And maybe you can help us sort of walk us through that as well, and particularly what the key needs are across the, maybe use an example of what the key needs are by different countries given their maternal mortality challenges.
Great. To turn over to the maternal health report, though, just a reminder, we have results by region, but not country for maternal health. But I might actually, maybe I'll start us looking at the comparison report, because I think there's sort of value in taking that big picture, and then we can maybe pick a region to zoom into a little bit more. So for maternal health, we are covering 7 what we're calling priority maternal health drugs, and then 3 emerging drugs. So these priority drugs were kind of brought together in 2021 based on a number of different efforts. So aligning to some work from R4D, looking at maternal health markets, looking at the 3 life-saving maternal health commodities, which are oxytocin, misoprostol, and magnesium sulfate. And so we wanted to really have a list that was bigger than those 3, but still manageable. And so we landed on this list of 7 priority drugs. And then there was interest from the community in exploring what we're calling these emerging drugs. So these are drugs that are either soon to be or already on the market, but still sort of changing and shifting, and so wanted in our future scenarios to be able to explore what would happen if those drugs scaled up more. So one of those is the multiple micronutrient supplementation that I mentioned before. The other two emerging drugs are heat stable carbetocin, which is a uterotonic used for PPH prevention, and then tranexamic acid, which is also used for PPH treatment. And so that is sort of our universe of drugs. So recognizing there's lots of other maternal health drugs, but this kind of seemed is where we coalesced around what was modelable and what were really some of the key priority drugs that were really leading to saving lives and improving maternal health outcomes. So for each of the drugs, we kind of take them group by group, and we start with a current landscape that is looking at the number of cases. And for maternal health, we analyze everything by cases because there's sort of one woman might have multiple different needs, right? So we didn't want our unit to be, pregnant women or live births. So by cases, we can account for the fact that you might need multiple drugs for one thing, or you might need different types of drugs because you experience different outcomes that require treatment. So here we can see the coverage of iron and folic acid. So here the need is all pregnant women because it is recommended that all pregnant women take iron and folic acid during pregnancy, but we can see that actual coverage is quite low. So around 17% across low and middle income countries and around 40% across lower middle and upper middle income countries. Next, we look at drugs for the treatment of and management of hypertension. And again, here we see actually across all income groups that coverage here is pretty low. So for some, and we'll keep going down, right? I think in some cases we see a much more dramatic kind of difference in coverage across countries by income groups. And in some places we just see it's sort of low for suggest different types of investments and interventions are needed where it's more of an equity issue versus where it's low everywhere and there might be more systematic barriers to seeing these things scaled up. We then look at magnesium sulfate for preeclampsia. So here you see that more kind of expected pattern of coverage kind of increasing as we look across country income groups. So around 30% in low income countries, 57% in lower middle, and 74% in upper middle of cases that need magnesium sulfate receive it. So quite a big discrepancy there. If we look at uterotonics, we're looking at misoprostol, oxytocin, and heat stable carbetocin. And again, we see a kind of similar pattern, but still quite a lot of unmet need, even in upper middle income countries. So lots of different barriers happening there. For TXA, we've just made an assumption of low coverage across all countries because we have very limited data. We know it's not zero because some countries have started to introduce it, but it hasn't really been scaled anywhere. So I think for this one, it's more about exploring what the future might look like. And then finally, we looked at metronidazole for maternal health infection. And again, see kind of low income countries lagging behind in terms of their coverage. And then if we look at the current costs, we see that a lot of the cost is coming from iron and folic acid. That's partly because just so many people need it and they need a lot of it, right? So if it's recommended for all pregnant women, and then those women are taking iron and folic acid throughout their pregnancy. So there's just a very high volume of drugs that are used. So that's part of why we see that much higher cost. And then we see some other kind of cost drivers. So you do that in relative view, you kind of see proportionally in each. So we see that methyl-dopa accounts for a sizable share, especially in low-income countries. And we see that metronidazole, so that's treatment for maternal health infection, accounts for a fairly significant share, especially in upper middle income countries. So a lot of variation in what those costs are. I'll also say, for the most part, donors are not buying these products. There are some instances where donors are stepping in to kind of fill emergency needs or in niche situations, like among displaced populations. But for the most part, governments are purchasing these drugs, or in some cases, women are having to purchase these out of pocket from pharmacies and then kind of bring them into the hospital setting. We have much less visibility into what the financing looks like here than we do for family planning, because you don't have those centralized procurement mechanisms among donors like we have for family planning. But in not all, but in most countries, again, these are largely already being purchased by governments. So I also think that contrast is really interesting in LEAP, right? Thinking about what can family planning learn from some of these other health areas, and what can some of these other health areas learn from family planning, because they've all been approached with very different financing mechanisms. And then for our future scenarios, we have a base scenario similar to family planning, where we just sort of maintain things. So the population grows, the number of births and pregnancies change, but we keep coverage the same. We have a second scenario where we increase coverage. We've chosen not to be overly aspirational, so countries are sort of shifted up to matching the coverage of the next highest country income group. So we're not suddenly jumping everyone to 100, but sort of building in some modest shifting of coverage. And then in scenario 3, we have that same change in coverage, but build in a more sizable change in drug use. And so this is where we kind of play with these levers around these emerging drugs, to look at what if they played a much bigger role in the future? What would the implications be for the costs? I'm going to jump to the costs because I think those are kind of the most interesting and useful results for this. So we can see, if we increase coverage without changes in drug use, that we have a pretty sizable increase in costs, going from about 28 million to 63 million, so 125% increase with our moderate shift in drug use, and then even more sizable, up to about 80 million when we introduce that bigger change in shifts in drug use. And a lot of that is because MMA is more expensive than IFA, at least right now. So if we have a big shift from iron and folic acid to micronutrient supplementation, sorry, MMS, not MMA, that we would see a lot more cost associated with that. That's a potential advocacy point, right? To talk about, if we think that there are health benefits of multiple micronutrient supplementation, that the cost would really need to be brought down to make it realistic to see it scale at the levels that people would like to see it scale. And then again, in lower middle income countries, we see costs increase from 122 million to 180 million in scenario 2, which is a much smaller relative change, so 48% versus an 83% increase to 223 million when we have the bigger changes in drug use. So yeah, I mean, I think these results can be helpful to think about, what is it costing now, and how much more would it cost if we wanted to see some of the improvements that we want to see in terms of both coverage, but also in terms of the potential of scaling up some of these emerging drugs. I don't know, B, did your discussions link to any specific drugs, or were kind of more general?
The discussions were focused on the priority drugs, on essential drugs.
Yeah,
Okay,
on the they were focused on the bundle of drugs kind of coming out of the emotive trials. So looking at the bundle of PPH prevention drugs. Yeah. So several that are included here.
Yeah. Yeah, and you can also look at this kind of drug by drug, so you could see what that looks like for some of those, right? So probably included like heat stable carbetocin, yeah, oxytocin and misoprostol as well. Sarah, we do not, so we have very little information about drug prices. So we are using um, global drug prices for this analysis, aligned to, I think mostly to the UNICEF list prices. Actually, this is a good, we can take a look at the reader's guide, which is up here in the corner, which has lots of extra detail. So if we come down here to maternal health, and then we come down here to drug costs, you can see the unit prices that are being used for all of the drugs. So yeah, these are mostly based on the UNICEF price catalog. And yeah, it's been interesting kind of trying to put cost estimates because there's just it's just such a different world, right? And again, you don't have the centralized procurement happening in the same way. And so it's just a very different world in terms of just visibility and availability of information about what drugs cost. And we know also, there's a lot of concerns around quality of drugs. So that's not something we've been able to kind of explicitly address in LEAP, but I think LEAP data can still help to feed into some of those discussions about, how much quality product would you need to procure to have sufficient amounts for use. And I will also say for a little bit in maternal health, but we also found some references, especially around abortion, that I think there's often been a notion that sort of quality and price are correlated. But more and more, I think we're seeing that is not true, right? That you have higher price drugs that are like if you plot kind of quality and price together, it is a very messy graph that we don't necessarily, right? It's not necessarily that those two are correlated together. So it's not necessarily that you need to spend more. It's just about what drugs are being bought, and in some cases, you might even be able to spend less and have higher quality products. And just while we're here, so this reader's guide is a handy place to get lots more information. So there's some overall sections that kind of give you definitions of all of our indicators that look at what countries are included. And then for each health area, we have this kind of same set of information that define key terms, look at scope, look at data sources, and then look at kind of use, quantities, costs, and future scenarios. So you can find lots more information hidden away in that reader's guide. So I'm mindful of the time and want to make sure we also get a bit of time on our kind of future looking brainstorming. So maybe just check if there's anything else people would like to take a look at here, and then maybe we can shift into that discussion.
Awesome. Thanks, Michelle. And I will say, so there are going to be kind of a series of additional sort of webinars and implementing mechanism meetings that look at the LEAP report. So this is kind of that first session. The Maternal Health Supplies Caucus will be hosting a session on a deep dive in the maternal health data. So if you want more information, you want to go a little bit deeper into that data, that is currently being scheduled. The Menstrual Health Supplies Workstream is doing a webinar on the menstrual health data that will be in late August. We'll be sending out a save the date for that shortly. The Safe Abortion Supplies Workstream will be doing a deep dive on the safe abortion supplies data that is planned for mid-September, with a save the date on that one forthcoming as well. And then finally, the MDA working group is going to host one on the contraceptive data. So another kind of opportunity to look at that data in more detail. So I will say, if there's areas that you want to go deeper into, keep an eye out for those, and the team will do kind of a series of different discussions about that. So just to put that on everyone's radar. And then following up on what Michelle was just saying, kind of the forward-looking piece, one of the things that we've been talking about is opportunities to better support advocates with navigating the LEAP report. And so one question that we had for all of you is just if we were to develop some sort of tool or some sort of toolkit or module kind of around using the LEAP report for advocacy, what type of information or guidance or resources would be helpful? So kind of beyond this overview of how to access the data and how to navigate the report, what else would you want to know, or what would be helpful in terms of format or just resources that we could make available? I'll give everyone a second to think about that, but feel free to put ideas in the chat. You're also more than welcome to email me or Michelle or Sophia, who supports the LEAP report from the RHSC Secretariat side. But yeah, just give that some thought and let us know if you have any reactions, or if you do have an initial idea, feel free to come off mute and share that with us. Amos or B, any reflections from either of you before we kind of move on to closing?
Yeah, I think for me, this has been so helpful. It's just that we don't have much time. I would have loved to hear more from colleagues in terms of how do we really move forward. And then, like you have suggested, we have opportunities in the other working groups if we want to hear more, go more into details, especially that we didn't dive deep in some of this information. And then I just want to echo back on what Ali mentioned. I think it's critical that if we are going to think through and use this information, we need to have a baseline in terms of where we're coming from and how this has improved and what has changed. I think it's critical that we see that. That will be very, very helpful. And then I will try, and colleagues, I would encourage you to also try and follow the remaining webinars so that we can get more details and see if that's very helpful for us in terms of developing messages for advocacy. Thanks, Sarah.
Thanks, Amos. B, anything else that you would add on your side?
No, thank you. I think Amos pretty much covered it. And Michelle, thank you so much for this presentation. It was really helpful and insightful. I think one of the things that's going to sort of move us in towards getting better advocacy messages will be getting more familiarity with the tool. And I would encourage everyone to take a look at it, try to play around with it and see what works for you. And as you do that, please feel free to share questions either through and definitely through the working group so that we can collate them and work with Michelle to address them. Because one of the things we want to be able to channel those questions in a way that's really helpful for Michelle to be able to give us, specific responses. So please, I encourage everyone, take a look at the LEAP report, take a look at the dashboard and make use of it.
Awesome. Thank you so much, B. So we will follow up as we always do with the recording and the meeting minutes from this meeting, and we'll also include some sort of kind of survey or opportunity to provide more feedback about kind of the types of resources or sort of analysis that might be helpful from an advocacy perspective. So stay tuned for that. And then we will circulate all the different save the dates for the webinars that take a deeper dive into kind of each of the commodity groups. So those are forthcoming, and definitely encourage you to attend those if you want more information about kind of how the LEAP report compiles this data, the data sources, and sort of what the data are saying, kind of based on the different commodity groups. So with that, I think we can wrap up for the day. Thank you so much, Michelle, for joining us and for all the hard work on the report. And thank you everyone for being here. We'll talk to you soon. Bye, everybody.